Hello. The topic of today's lesson is diseases of endocrine organs in animals. In particular, diseases of the adrenal glands. Today we will study such a disease as hypoadrenocorticism, which is also called Addison's disease. It is an uncommon disease in dogs, and it is caused by a deficiency of essential hormones that are made by the adrenal glands. Primary hypoadrenocorticism occurs when the adrenal glands are damaged. In this case, the level of hormones such as cortisol and aldosterone decreases. Secondary hypoadrenocorticism occurs when the production of adrenocorticotropic hormone, ACTH, decreases due to a malfunction of the pituitary gland. This hormone stimulates the adrenal glands to secrete cortisol. Therefore, with its deficiency, stimulation of the adrenal glands and the content of cortisol decrease. Primary hypoadrenocorticism, also known as Addison's disease, is a syndrome caused by bilateral dysfunction of the adrenal cortices. Primary hypoadrenocorticism, the classic form of the disease, is characterized by a deficiency of glucocorticoids and/or mineralocorticoids. It is most commonly reported in young to middle-aged female dogs. Atypical hypoadrenocorticism generally occurs at older ages. This disease rarely occurs in cats. There is also a hereditary predisposition to the disease in certain breeds of dogs. Standard Poodle, West Highland White Terrier, Great Dane, Bearded Collie, Portuguese Water Dog, Nova Scotia Duck Tolling Retriever, Soft-coated Wheaten Terrier. Primary hypoadrenocorticism typically results from immune-mediated destruction of adrenal cortical tissue. Nearly 85 to 90% of adrenal tissue must be destroyed before substantial biochemical and clinical manifestations occur. Other possible causes of secondary hypoadrenocorticism: idiopathic, necrosis, hemorrhagic infarction, metastatic neoplasia, amyloidosis, granulomatous destruction, blastomycosis, histoplasmosis, cryptococcosis, drug-induced, mitotane, ketoconazole, trilostane. Addison's disease can also occur following treatment of Cushing's disease, in which too much cortisol and aldosterone are produced. A secondary form of disease can result from a tumor or defect in the pituitary gland, which is an important hormonal regulator located in the brain. Secondary hypoadrenocorticism can also develop if a dog has been treated with long-term steroids for any reason and the medication is abruptly stopped. This last condition is known as iatrogenic hypoadrenocorticism and is generally temporary. Hypoadrenocorticism may form part of a polyglandular autoimmune syndrome in some dogs, which can also include hypothyroidism, hypoparathyroidism, and diabetes mellitus. For further understanding of the pathogenesis of the disease, here is presented normal feedback regulation of cortisol and aldosterone secretion. Let's consider the pathophysiology of hypoadrenocorticism from the point of view of a deficiency of aldosterone and glucocorticoids. A decrease in the level of aldosterone leads to a reduced ability to conserve sodium and chloride and excrete potassium and hydrogen ions. In addition, sodium loss may be further increased by vomiting, diarrhea, and reduced feed intake, i.e. anorexia. Loss of sodium and chloride leads to loss of water concurrently and volume depletion, reduced cardiac output and decreased glomerular filtration rate. Reduced perfusion to the gastrointestinal tract can potentially lead to gastrointestinal ulceration and acute pancreatitis. Decreased renal perfusion leads to increased hyperkalemia. The excitability of the myocardium and other muscles decreases, which causes bradycardia and weakness. Pathophysiology of glucocorticoid deficiency. Decreased glucogenesis and fat metabolism, resulting in hypoglycemia. A decrease in cortisol in the central nervous system can lead to lethargy and depression. Cortisol is also necessary for the normal functioning of A, and its reduction contributes to vomiting, diarrhea, and lack of appetite. Cortisol stimulates appetite and red blood cell production, so its deficiency can lead to loss of appetite and anemia. In adrenal insufficiency, the secretion of adrenocorticotropic hormone by the pituitary gland increases and stress tolerance is impaired. Atypical hypoadrenocorticism develops when only glucocorticoid deficiency is present. Classified as atypical when the typical electrolyte changes were not present, i.e. hyperkalemia and/or hyponatremia. However, recent work has shown that cases of typical hypoadrenocorticism do not always have electrolyte abnormalities. These cases tend to be older at the time of diagnosis and have a longer duration of clinical signs when compared to cases of typical hypoadrenocorticism. More likely to be anemic, hypoalbuminemic, and hypocholesterolemic than typical hypoadrenocorticism cases. Diagnosis in these cases is particularly difficult. Diagnosis is based on evidence on lack of cortisol but not aldosterone stimulation on an adrenocorticotropic hormone stimulation test. These cases may progress over time to become deficient in mineralocorticoids as well. However, in some cases animals have been monitored for several years with no development of electrolyte abnormalities. The clinical presentation of hypoadrenocorticism can vary in severity, with waxing and waning episodes of illness that classically worsen during times of stress. Symptoms of the disease are not specific. In animals, lethargy, diarrhea, vomiting and hematemesis, vomiting with blood, are observed. Animals increase thirst and urination. The animal loses weight for no apparent reason. Intermittent shaking episodes are sometimes seen. Melena is common in dogs with hypoadrenocorticism. Because of ileus, which is common in dogs with hypoadrenocorticism, melena may not be apparent for 2 to 3 days. Based on the signs noted in table, it is understandable that atypical hypoadrenocorticism, when only glucocorticoid insufficiency occurs, is more challenging to diagnose because signs related to isolated glucocorticoid deficiency are more insidious. These are clinical signs such as lethargy, weakness, shaking, polyuria, polydipsia, vomiting, diarrhea, abdominal pain, inappetence, weight loss. An Addisonian crisis, or adrenal crisis, is a potentially life-threatening condition that results from an acute insufficiency of adrenal hormones, glucocorticoid or mineralocorticoid, and requires immediate treatment. In these cases, there is a sudden weakness with severe vomiting and diarrhea, and sometimes collapse. Diagnosis based on medical history, including any medications, clinical signs, and the results of common blood and urine tests, most notably electrolyte imbalances. The most definitive diagnostic test for Addison's disease is the ACTH stimulation test. Additional tests such as basal cortisol levels, natural plasma ACTH, electrocardiogram, radiographs or abdominal ultrasound may be performed to rule out another cause for your pet's clinical signs. In rare instances, MRI or CT may be needed to diagnose a pituitary gland problem. Common clinicopathologic abnormalities in dogs with hypoadrenocorticism: hyperkalemia, hyponatremia, hypochloremia, acidosis, azotemia, hypoglycemia, increased alanine and aspartate aminotransferase levels, hypercalcemia, hypoalbuminemia, hypocholesterol, anemia, hypoglycemia, eosinophilia, lack of stress leukogram, lymphopenia secondary to cortisol release. Diagnostic imaging is not typically required for the diagnosis of hypoadrenocorticism. Some ultrasonographic and radiographic signs can be helpful. As you might expect, ultrasonography has shown that the adrenal glands are shorter and thinner in affected dogs than in those of their unaffected counterparts. Radiographs may indicate hypovolemia, e.g., small heart and liver, and decreased diameter of the cranial lobar pulmonary artery and caudal vena cava. To confirm hypoadrenocorticism, an adrenocorticotropic hormone, ACTH, stimulation test must be performed. This test is performed by measuring serum cortisol concentrations before and 1 hour after administration of synthetic ACTH. Procedure for performing ACTH stimulation test: collect a blood sample into a tube. Administer 5 micrograms per kilogram of synthetic ACTH, up to a maximum of 250 micrograms per dog. Avoid use of compounded formulations. After 60 minutes, collect a second blood sample. Submit both serum samples for cortisol measurement. A diagnosis of hypoadrenocorticism can be made when post-ACTH cortisol levels are less than or equal to 2 micrograms per deciliter. For animals with properly diagnosed hypoadrenocorticism, the prognosis and quality of life are good. Most of these animals die of something unrelated to hypoadrenocorticism. Treatment of the chronic form of the disease. For most patients who are clinically stable, treatment consists of supplementation with a mineralocorticoid and a glucocorticoid. Mineralocorticoid supplementation is available in two forms: daily oral, fludrocortisone, and monthly injection, desoxycorticosterone pivalate. Fludrocortisone acetate possesses both glucocorticoid and mineralocorticoid activity. Although the dual functions may seem like a benefit, they can make it more difficult to titrate the drug to an acceptable dosage. Because DOCP has only mineralocorticoid activity, concurrent glucocorticoid, e.g., prednisone, supplementation is always necessary. All patients receiving DOCP must receive supplemental glucocorticoids. Some patients receiving fludrocortisone do not require additional prednisone long-term, but these patients seem to stabilize more quickly when additional glucocorticoid is given initially and then tapered after stabilization. For glucocorticoid replacement, oral prednisone at a starting dose of 0.5 to 1 mg per kilogram per day is usually recommended. This dose should be gradually lowered, over several weeks, to an optimal dose that controls signs of hypoadrenocorticism and avoids side effects, e.g., polyuria, polydipsia, polyphagia, panting. Larger dogs seem to be more sensitive to the side effects of glucocorticoids. Dosage adjustments should be based on clinical signs only. For dogs with confirmed naturally occurring hypoadrenocorticism, an ACTH stimulation test should not be repeated for monitoring purposes. Treatment for Addison's crisis includes the elimination of such symptoms as hypovolemia and hypertension, acidosis, hyperkalemia, hypoglycemia, severe anemia from gastrointestinal blood loss, glucocorticoid deficiency. Supportive therapy is also necessary, including warming measures if patient is hypothermic, antiemetics, gastroprotectants, pain management, nutrition. Patients are usually eating within 24 hours. And thank you for your attention.